Yeah, so it's recording also, and we'll upload it to the link so anyone can watch it. So today we'll do epilepsy, and this is Kishara's note, so we'll quickly go through it. So we'll first go through some definitions that are important and the classification of seizures, and then we'll look at the investigations and the management, history, examination, and how to approach a long case basically. So a seizure, the definition of a seizure is a set of clinical symptoms associated with abnormal electrical activity in neurons in the cortex of the brain. Okay, so it's basically abnormal electrical discharges or abnormal electrical activity in neurons in the cortex of the brain. The clinical characteristics of a seizure are the result of the area of the brain that is abnormally stimulated. Okay, so epilepsy is a clinical condition in which there are multiple seizures that are unprovoked. There is a definition for epilepsy later on. There are 3 criteria where we can diagnose epilepsy. We'll look at those in a bit. Right. So there are also provoked seizures. Provoked seizure is basically seizure induced by a particular condition originating outside of the brain. Okay. For example, like fever, infection. Okay. Then head trauma, hypoxia, electrolyte imbalances, toxins. Okay, and even arrhythmias. They can even arrhythmias and syncope are more like it would give like syncope, which is a differential diagnosis of seizure. Okay, so in this provoked seizure, the thing is, if you identify the underlying cause and if you treat the underlying cause, then this seizure will stop. So that means you don't have to treat with anti-epileptic drugs for this. So when you are taking a sort of long case is a seizure or if it's an epilepsy case, you need to also think of underlying causes which can result in a seizure. Okay, so you need to ask questions regarding that. So we'll look at those in a bit when it comes to the history taking parts. Right. So electrolyte imbalances such as hyponatremia is a very common cause, which a very common electrolyte imbalance which can lead to epilepsy, seizure. Sorry. Then other metabolic causes such as hypoglycemia. Okay, so in a patient that comes with a seizure or suspected seizure, very important to do a CBS at least. Okay, like one of the first initial investigations you would do, especially in a status epilepticus. Okay. Then other electrolyte imbalances such as hypocalcemia also can result in seizures. Okay. So yeah, these are the new criteria to diagnose an epilepsy. Okay, epilepsy, the old criteria was recurrent unprovoked seizures. But now there are 3 points. If at least one of these are fulfilled, you can diagnose an epilepsy. So first one is at least 2 unprovoked seizures occurring more than 24 hours apart. Okay. Then the other one is this second one. It's a bit of a long definition. In simple, what this means is 1 unprovoked seizure and the risk of recurrence is more than 60% over the next 10 years. Okay, so if you can't remember this entire sentence, it's basically in simple is 1 unprovoked seizure and the risk of recurrence is more than 60% or at least 60% over the next 10 years compared to the general population. Okay. So an example for this number 2 would be, think there's a patient with a stroke, a patient who has had a stroke around 3 to 4 months ago. Okay. This patient, he has had a left-sided stroke with right-sided hemiplegia, now presenting with a right-sided focal seizure, which is compatible with the lesion. So this patient has had a stroke on the left side with right-side hemiplegia, like 4 or 5 months ago, let's say, for example. Now this patient is presenting with a right-sided focal motor seizure, which is compatible with the lesion. Okay, so that patient already has some sort of neurological, like what you call dysfunction. A past stroke can increase the risk of recurrence of a seizure. Okay, so this patient would have a high chance of developing recurrent seizures. Okay, so for that patient, even with the first seizure following a stroke, like sometime after a stroke, you can treat with anti-epileptic drugs even after the first seizure. Because that patient, compared to the general population, a patient who has had a stroke in the past, if they are now presenting with seizures, or 1 seizure even, that patient is likely to have a higher risk than the general population. Then you might even consider starting anti-epileptic drugs even with 1 seizure. Okay. So the first definition was 2 or more unprovoked seizures occurring more than 24 hours apart. Second definition is 1 unprovoked seizure, and the risk of recurrence is more than 60% over the next 10 years. So remember that example, patient with a stroke coming later on with a seizure that is compatible with the anatomy or the lesion of the previous stroke. Then again, you can diagnose an epilepsy, and you might even start anti-epileptic drugs even after the first seizure. Okay, and then diagnosis of an epilepsy syndrome. These, I think, the epilepsy syndromes, you might know it very well in the pediatrics, but even in adults, there are some epilepsy syndromes that we need to know of. Okay, it's not only in pediatrics. When you say epilepsy syndrome, a lot of people think it's mainly pediatrics, but in adults also there are some syndromes that you need to know. If you get kishara for the long case, he will definitely ask about these epilepsy syndromes. Okay, so he has asked some of our previous groups. He has asked. Okay, so remember these three slides points are important. This cellular mechanism of seizure generation, you can just read about it, but I don't think anyone's going to ask into detail. Basically, there's an imbalance between the excitation and inhibition. When there's too much of the excitation, such as the neurotransmitters glutamate and aspartate, and too little of the inhibitory neurotransmitters such as GABA, that is gamma aminobutyric acid, it can result in seizures. Okay. Yeah, so normal CNS function, there's a balance between excitation and inhibition. When there's an imbalance, when the excitation is too much or when the inhibition is too less, you can get seizures. That's the basic underlying mechanism. And the drugs also act to bring about this balance, basically. Okay. Okay. So then this ILAE classification, that is International League Against Epilepsy classification of seizure types. This is, you must know, this is a must know slide, the classification of seizures. In your history also, you need to try and figure out what kind of seizure this patient has, okay? So there are three main classifications. One is focal onset. Focal onset means the seizure. That means the abnormal electrical discharge is limited to one cerebral hemisphere. Okay. So if we draw the cerebral hemispheres, I'm just drawing on the slide, these are the drawings. So if we take the cerebral hemispheres, okay, so just think of these two as cerebral hemispheres, right side and maybe left side. Okay. So focal onset is basically seizure originates from one side of one cerebral hemisphere and it remains within that cerebral hemisphere, or it remains within that focus where it originates from. Okay, so focal onset. So your clinical features, your tonic movements or clonic movements, or the tingling sensation, whatever, it will depend on the side of origin. It will depend on the site of origin. And also if it remains on one cerebral hemisphere, the clinical features, you will see it only on one side. So if the impulse is on the right side, right cerebral hemisphere, the clinical features are likely to be seen on the left side because the fibers cross over, okay, at the brainstem. So you might see like tonic-clonic movements on the right side. Generalized or general onset seizures, that is basically the abnormal electrical discharge originates from one side and then there's rapid involvement of both the cerebral hemispheres, okay? So the clinical features are seen on both sides. The tonic-clonic movements, atony or sensory impairments can be there on both sides. Okay, focal onset is one cerebral hemisphere, so only one side is involved. General onset is basically, it develops from one side, okay, and there's rapid involvement of both the cerebral hemispheres. So in practice, it's a bit difficult to see it progressing from one side to the other. You generally see it as both sides being involved at once, okay? Yeah. There's also, yeah, I'll come back to that later. There's nothing called focal to generalized. We'll look at that. Unknown onset is basically when you don't know the onset. Basically, if you have walked in on a patient towards the end of the seizure, you don't know where it originated from. You don't know if one side has been involved or both sides have been involved from the beginning. Because this focal onset, yeah. So before the unknown onset, I'll come to this other term that was used before. Have you all heard of secondary generalized seizures? That was a term that was used in the past. Okay, secondary generalized seizures was a term that was used in the past. So that is basically, a focal onset seizure which spreads to the other side, but not as rapidly. So the clinical features, you would see one side being involved, and then gradually there's involvement of the other side. That is what is known as secondary generalized. Generalized seizures is when both the cerebral hemispheres are involved sort of rapidly. Okay? That is generalized onset. Secondary generalized means secondary generalized seizure is an old term. Now what they call it, focal to bilateral. Okay? That means focal onset, and gradually there's involvement of both the cerebral hemispheres. Okay. That is basically the classification. Unknown onset is basically when you haven't seen the seizure from the beginning. So if both the sides are involved, you don't know if it was involved from the beginning. You don't know if it's a proper generalized onset, or you don't know if it's a focal to bilateral seizure. Okay, I hope that is clear. Yeah. So then focal onset seizures can be classified again into two, whether the awareness was impaired or not, or whether the awareness was impaired or not. If the awareness was impaired, it's known as impaired awareness. Whether if the awareness was not impaired, it's known as aware. Then again, you can classify it into motor onset and non-motor onset. Okay, so motor onset is this atonic, clonic, myoclonic, tonic seizures around that. Non-motor onset is basically the autonomic features, cognitive, emotional, and sensory. Okay, like autonomic features, cognitive, emotional, and sensory ones. Okay. Generalized onset also similar motor and non-motor onset. So tonic, clonic, myoclonic, okay, atonic. And non-motor is also like absence seizures. Okay. Unknown onset also you can classify it as motor and non-motor. Right. So once again, the classification is very important. I'll go through it again. Focal onset is basically when the seizure or the abnormal electrical discharges are limited to one cerebral hemisphere. Generalized onset is basically when there's rapid involvement of both the cerebral hemispheres. So from the beginning itself, both the sides are involved. And there's a small subclassification known as focal to bilateral tonic-clonic or focal to bilateral. This was what was known as secondary generalized seizures in the past. That is when the seizure originates from one side and there's gradual involvement of the other side. So in practice, what you see is you might see tonic-clonic moves on the right side, and as the seizure progresses, you might see it progressing onto the left side as well. Okay, that is different from generalized onset seizure, where in generalized onset, both the cerebral hemispheres are involved from the beginning itself. Unknown onset is when you haven't seen when say a patient is having a seizure in the next room, but you haven't seen the beginning of it. So if both the sides are involved, you don't know if it's a generalized onset seizure, or you don't know if it's a focal to bilateral tonic-clonic seizure. Okay, so it's a bit hard to differentiate, then it's an unknown onset. Then when it's a focal onset seizure, you classify it based on the awareness, whether the awareness is impaired or whether the awareness is not impaired. And then further, you can classify it to motor and non-motor. Focal onset motor, you have the tonic, clonic, atonic, and myoclonic, and these other small ones. Non-motor onset, you have the autonomic, cognitive, emotional, and sensory. Okay. Generalized onset, you have again motor, non-motor. Motor has the tonic, clonic, myoclonic, atonic ones. Non-motor has the absence seizures. Okay. Absence seizures are where they are generally like just staring, brief periods of unresponsiveness. Okay. Unknown onset also can classify as motor and non-motor. So this slide is a must-know slide. Okay, it's very important. Right. So even in your history, when you're taking the history, you need to ask the patient. Generally, in the long case, if it's obviously the patient who's undergone the seizure, so they're unlikely to really know what side was involved, especially if they lost their consciousness. So you have to go with what the bystander says. But in the exam, you don't get a bystander. So the patient might know something that the bystander has told them already. Okay. So then you have to try and get an idea whether, whether it was the left side that was involved or the right side, whether the upper limb or the lower limb, or whether it's both sides. If it was both sides, whether both sides were involved at the beginning, Or initially did it start from one side and then did it progress to the other side? So those are like important questions you need to ask in order to sort of classify it into these three. Okay. Yeah. So again, focus seizure, this is again explaining like it originates from one side and is limited to one side. Okay. Please, I'll have a look at this slide. Okay. So when you might have heard about this tonic clonic terms. So tonic basically means stiffness. Okay. When the limbs go stiff, okay, there can be some crying out, there can be tongue bites. Okay, because all the muscles become stiff, their respiratory muscles, intercostal muscles can get affected. So their breathing might be hindered. There can be periods of apnea, cyanosis. Okay. And with these features, they can have some autonomic disturbances such as increased heart rate, blood pressure. But these usually go undetected because at home, if the seizure has occurred at home, they don't really check the heart rate, blood pressure at home unless there's some medical person. But these are the features that you might have to ask about, like whether they bit their tongue, whether they was like crying out. It's called like an ictal cry. Okay? Whether they sort of made like a somewhat of like a grunting or like a crying noise. Okay, whether their limbs went stiff. Okay, they might sustain falls. Okay, when the limbs go stiff, they might sustain falls as such. Clonic phase is when they're sort of like jerky or intermittent. Clonic is like jerky movements of the muscles. Okay, so this can involve any limb. It can involve all the limbs. It's a generalized seizure. Okay, and there can be some incontinence at the end of clonic phases. Okay. Then the post-ictal period, there can be drowsiness, confusion, headache, body aches, sleepiness, and all that. Right? So differential diagnosis, this is very important. There are two main groups. Okay. One is psychogenic non-epileptic attacks, and the other one is physiological non-epileptic attacks. Okay? Or physiological non-epileptic paroxysmal disorders. So psychogenic spells are usually to do more towards the psychiatric side. Okay, like the panic attacks that you get, conversion disorders, psychosis, malingering, Munchausen syndrome, okay, hyperventilation syndromes, those kind of stuff. Those are the psychogenic spells. Okay, physiological non-epileptic attacks, syncope is the #1 DD for epilepsy or seizure, okay? For the seizure, not epilepsy, mostly for seizure. Right, so this is the first DD that you need to exclude. How we find the differences, I'll come to that in a bit. Okay. Then migraine, you can basically any sort of other CNS cases, you can put them under the DDs for epilepsy, like migraine, transient ischemic attack, or even a stroke if there's like sensory impairment and motor weaknesses and stuff. Okay. Yeah, those are the main things. Right. Then there are other sort of provoked seizures, like I told you, the infections, meningitis, encephalitis, the metabolic imbalances, hypoglycemia, hyponatremia, head trauma. Those can cause seizures. Those are provoked seizures. So those also you need to ask in your history for the DDs. Okay, rather not for the DDs, rather than like underlying causes, so etiological agents, factors for seizure. Yeah. So before we come to that, we look at how to differentiate between epileptic seizure and a syncopal attack. Okay. So I hope everyone can see this. I changed it to a Word document. Epileptic seizure and vasovagal syncope or syncope. Right. So this was an SCQ of, I think, 28 or something like that. There was an SCQ for medicine, and also there was an SCQ for peds. So differences are pretty much the same. You can remember this for peds as well if anyone's doing it. Precipitating factors or events in epileptic seizures, they may or may not be present, okay? Like sleep deprivation, photic flicker. Photic flicker means like flashing lights, even loud noises, exhaustion, okay? Drugs and stuff, alcohol, like that. Vasovagal syncope, there's almost always a precipitating factor, like prolonged standing, hot environment. I'm sure most of us Some of us may have experienced it. Some of us may have even heard or seen like friends at school in the assembly time when they have to stand in the hot sun, or even in sports meets, you have to stand and wait for some time in the hot sun. You must have seen or even heard about fecal pain, right? So those are precipitating factors. In syncope, they are almost always present. Crowded places, unpleasant circumstances, pain, venipuncture like blood drawings. You might even come across patients or children that faint when you try to draw blood. Okay, visualizing blood, sudden fright. Okay, some precipitating factor is usually almost there in syncope. Posture. When it comes to the posture, epileptic seizure can occur in any posture. Vasovagal syncope generally tends to occur when the patients are upright. Okay, because this vasovagal syncope is due to sort of reduced cerebral perfusion. So that generally tends to occur in more of an upright position. That's why when a person sort of faints, you tend to like sit them down or lie them down on the side so as to like improve the circulation to the brain. Okay. Usually, I generally never when walking or running. Okay, because at that time your perfusion to the organs are like improved. Pallor and sweating. So these may or may not be there, generally unusual in epileptic seizures. Vasovagal syncope, very typical, okay? If you have had fainting episodes, if you're seeing someone faint, you might have noticed that they sort of go pale or they start sweating a bit before the fainting episode, especially they sweat, okay? Onset, epileptic seizure often sudden. Okay? One moment the person is okay, next moment they might be having a seizure. Whereas vasovagal syncope, there can be a prodrome. Okay? They might feel like very uncomfortable. They might feel sort of sweating. You might see the sweating. Okay, they might have some blurry vision or something like that. Tongue biting in epileptic seizure much commoner than in a vasovagal syncope. Okay. Convulsive jerks, these tonic-clonic movements, commoner in epileptic seizures. In vasovagal syncope, you can get them, especially these brief myoclonic jerks. Okay? Okay, you can get them. It's not that they don't occur, you can get them, but not as common as is epileptic seizure. Incontinence, usually in seizures with loss of awareness, that also it can occur. It's much commoner than in syncope. In syncope, it's not that common, but may occur. Okay, so be careful with these terms. It's like it may occur. Unconsciousness, epileptic seizures may last a bit longer, whereas vasovagal syncope, it lasts shorter, maybe seconds. Recovery is often slow with epileptic seizure. Vasovagal syncope, it's rapid. Okay? And generally, when you lie down the person, they tend to sort of regain consciousness pretty fast. Post-ictal drowsiness. After the episode, the drowsiness following a seizure is usual, is common, whereas in vasovagal syncope, it's unusual. Okay? Sort of the drowsiness is less. If they have drowsiness, the duration of the drowsiness is less. Whereas in epileptic seizure, the post-ictal drowsiness is commoner and the drowsiness may last long. So these are the differences. This is also must know. Okay, this is a must know slide or rather graph. They can ask the SCQs, they can ask in the long case. Okay? And these are the features that you need to ask in the history also. Okay? So in the history, I'll tell you how to ask the history. Basically, you need to ask what they were doing beforehand. Okay, what position they were in, did they feel anything, was there like sweating, okay? Onset, how long did it last for, the recovery, and post-ictal drowsiness, tongue bias during incontinence and stuff like that, you have to ask. So we'll look at the history part in a bit. That is epilepsy versus a syncope, okay? In epilepsy and pseudoseizure. Pseudoseizure is basically when someone tends to sort of fake a seizure. Okay. So this also can be asked. When we did the neuro appointment, James Russell asked this, and we wanted one specific component, which is sort of like a mandatory feature to differentiate the two. So we look at these. These also can be asked in the SCQs. I think this was asked in an SCQ before, but this has not been asked yet. So maybe it might come even, or maybe they can ask in the buckets, right? So yeah, epileptic seizure and pseudoseizure, that's when they tend to fail. So consciousness. So retained consciousness can be rare. Okay, so loss of consciousness is much more common in a true seizure than a pseudo seizure. Okay, so they tend to retain the consciousness because they're like faking it, right? Then there are some characteristic movements which are common in pseudo seizures, like this pelvic thrusting. Okay, asynchronous limb movements. Okay, usually in a true epileptic seizure, the limb movements are sort of synchronous. Okay, whereas in a pseudo seizure, they're asynchronous. There's no particular sequence of the movement. Body rolling also more with pseudo seizure and less common with epileptic seizure. Okay. Cyanosis may occur with a true epileptic seizure. I told you with the tonic phase, there's some apnea because the muscles become stiff and there can be some cyanosis, whereas in a pseudo seizure, it's unusual. Tongue biting also, there's a difference. Both can have tongue biting. In an epileptic seizure or a true seizure, the tongue biting is typically lateral. Pseudo seizure, tongue biting is at the tip. Okay. So these are small differences which can help you differentiate between a true seizure and an epileptic seizure. Okay. Yeah. Duration, epileptic seizure may go up to minutes, seconds or minutes. Pseudo seizure, they're faking it, right? So they want to get a lot of attention. Okay. Usually pseudo seizure, it's mostly to like draw attention to themselves or get away from situations. So it can be prolonged. Okay. This part, this is the most important part. This is what Bimsha was expecting us to say first, actually. Resistance to passive eye opening. Okay, that means in a pseudo seizure, the eyes are closely, like tightly shut. Okay, and whereas in a epileptic seizure, generally the eyes are open. Or rather, in a pseudo seizure, the eyes are tightly shut. Even when you try to sort of passively open the eye, if you try to open the eye with using a finger, they will resist it and they will keep their eyes closed, which is very unusual in a true seizure. Okay? In a true seizure, if a patient is having a true epilepsy or true seizure, you can sort of open their eyes using your fingers. Okay. Whereas in a pseudo seizure, I told you they're faking it. They try to like sort of avoid eye contact and avoid like looking at people. So they tightly shut their eyes. That is also this gaze aversion thing. They tend to avoid the eye contact. They look away from it. Okay. Post-ictal drowsiness is commoner with the epileptic seizure because it's a true seizure, right? Whereas in a pseudo seizure, unusual. Okay. Ictal EEG abnormality. So at the time of the seizure, if you do an EEG, epileptic seizure, there may be some abnormalities. Okay. And I think EEG is not diagnostic of seizure or epilepsy. So there may be abnormality. Even though there are no abnormalities, you can't say that it's not an epileptic seizure. So we'll come when I'll discuss that in the investigation. Pseudo seizure, there are generally no EEG abnormalities usually. So it's a normal EEG. The environment, epileptic seizure can occur in any environment. Pseudo seizure, I told you they're faking it. They want to draw attention. They want to get away with situations. So often in the presence of someone else. Okay. So these two are must-know slides. Okay. So I'll send you this. So if you haven't written it down, it's fine. Can ask in the SCQ, can ask in the long case, can ask for medicine and pediatrics both. Okay. So again, these slides are basically describing what I said. Okay. This is the part. Okay, say this first. If someone asks you how to differentiate between a true epilepsy and a pseudo seizure, say this first. The ictal eye closure. Okay. Physiological non-epileptic seizure or a pseudo seizure. In a pseudo seizure, this eye closure is a reliable indicator. Okay. This person I'll just rush through why this syncope can mimic a seizure is. I told you syncope, the vasovagal syncope occurs when there's reduced blood supply to the brain. Okay, so that can sort of stimulate the reticular formation in the brain, and it can result in increased tonicity, myoclonic jerks, and so on. Okay, so it can mimic a seizure. Where you lose consciousness, you can have this myoclonic jerk, so it can mimic a seizure. Okay. Some bedside tests that might sort of help you sort of give a clue as to whether it's a syncope or not is this. Confirmatory testing can include simple bedside tests such as checking for orthostatic blood pressure change. If there's postural hypertension or orthostatic hypotension, you might think of a syncope as well. Okay, I told you because with orthostatic hypotension, the blood flow to the brain reduces, so they can have some degree of hypoxia and those myoclonic jerks and loss of consciousness. Pulse checks and cardiac auscultation. Pulse check is important because arrhythmias can result in syncope. Okay, so arrhythmias can result in syncope. So syncope is a DD for epilepsy. So pulse check is also important. So these are things that you need to check in your examination part in the long case. Even you might not have the time, to check the postural blood pressure, but you can offer it even if you don't have time. But definitely pulse check is needed. BP also, if you can check the norm, you anyway have to check blood pressure in all patients. If you can't do the postural hypertension, it's fine. But pulse check is mandatory, especially stress on the fact that it's regular or not and stuff like that. Cardiac auscultation is also important in the epilepsy case because cardiac arrhythmias can result in syncope. So you need to tell the examiner cardiac auscultation was normal. There were sort of no murmurs. Okay, because murmurs or valvular lesions can cause arrhythmias. Okay, and you need to tell them specifically that the heart sounds were normal, pulse was regular, whatever beats per minute, like that. Okay, basically by saying those, you are excluding the possibility of a syncope in the cases. Okay, and if you are still suspecting, you can do these other investigations, ECG, echo, and stuff like that. Okay. Know the bedside test because that is what you can do in the long case, right? Okay, up to that point, I hope it's clear. Basically, we discussed what a seizure is, what an epilepsy is, okay? The classification, must, no slide. What happens in tonic movements, tonic phase, post-ictal period, the DDs, okay? And then how to differentiate the epilepsy, syncope, and epilepsy and pseudo-seizure. Then we'll come to epilepsy syndromes. Okay, so a syndrome is basically defined by a group of features occurring together. So epilepsy syndromes, when you hear it for the first time, you might think about pediatrics, but there are epilepsy syndromes in adolescents and adults as well, mainly these three. So if you get kishara for the epilepsy case, and if you answer well, he might even ask about these, okay? Because these are from his slides. He generally tends to ask questions straight off his slides. So we'll go through these three, because these, when you talk about epilepsy syndromes in adults, the first three are the common ones. The bottom three are less common. So common ones are juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. Okay. So for this part, I hope everyone can see the whiteboard. Right? So in epilepsy syndrome, or in genetic seizures, there is a triad. Okay, there is a triad. So one is generalized tonic-clonic seizure. Two is absence seizure. Three is myoclonic seizure. Okay, so the triad of seizure can go in any direction. Okay? So patient with an epilepsy syndrome can get any of these three seizures. Okay? So how we classify the syndrome is, basically the clinical syndrome depends on the predominant seizure type. For example, in juvenile myoclonic seizure, Okay, so that is one of the epilepsy syndromes in adults. Okay, in juvenile myoclonic seizure, the predominant type is myoclonic seizure. Okay, so once again, in adults in epilepsy syndromes or in genetic seizures, there can be a triad: generalized tonic-clonic seizures, absence seizure, and myoclonic seizure. Okay. Generalized tonic-clonic means both sides, tonic-clonic movements. Myoclonic seizures are basically, myoclonic movements are sudden muscle contractions that last for like milliseconds. They often go unnoticed. It's like something like being electrocuted. Your muscles just twitch for like milliseconds and it sort of relaxes. It might even go unnoticed, okay? But if it's repeated, you might see just twitching. Absence seizures are generally just, there's brief loss of like awareness. They're just blankly staring into space. Okay, so this is the triad: GTC, absent, and myoclonic seizure. The clinical syndrome in adults depend on the predominant seizure type. In juvenile myoclonic seizure, the predominant type is myoclonic seizure. Okay. In juvenile absence seizure, the predominant type is absent seizure. Okay. Then epilepsy with generalized tonic-clonic seizure alone, the predominant type is GTC. So I hope that's clear. There's a triad, and the syndrome is based on which seizure is predominant. They can get all three, okay? But depending on what is predominant, you classify them into the seizure type. Okay. Generally, these generalized tonic-clonic seizures are the more dramatic ones. So even if they have one of them, the diagnosis of like an epilepsy or seizure occurs after this. But if you go in detail into the history, you might find out that the myoclonic seizures are even more predominant. You might find out that absence seizures are more predominant. So then you classify accordingly. Right. Back to the slides. So those are the, back to the PowerPoint. So those are the type of epilepsy syndromes in adults. You know the first three. So I can ask. He has asked these in the past previous groups. What are the epilepsy syndromes in adults? So don't say, I don't know. You can say confidently now, three main types: juvenile absence, juvenile myoclonic, and epilepsy with GTC alone. Even though it's alone, these other two can occur, but GTC is the predominant one. Okay. Then you can say that there's a triad, and depending on what is more predominant, you classify it accordingly. All right. So yeah. See, juvenile myoclonic epilepsy characterized by presence of myoclonic jerks on the awakening. Okay. Infrequent GTCs and typical absence seizure. So GTC and absence seizure also can occur, but they are less frequent than these myoclonic jerks. The age of onset vary from about 8 to 26 years. And juvenile myoclonic seizures, they're very responsive to valproate. So those can be like MCQs, right? There haven't been much MCQ asked from epilepsy, but these are possible MCQs, okay? Like the drugs and what is better and all that. And the other difference is in pediatrics, you might have come across childhood absence. Yeah, so that's a good question, how to ask these in the history. So basically, you will have to ask if they've had in the past, like have they had any episodes of just staring, or usually the patients might not notice these. But you can ask them if they have ever been told that they've been found staring into like, just unresponsive staring, or whether they've had like brief muscle twitches that, he has not taken much notice of, or he has not taken, not thought too seriously about. Okay, you can just ask them to show the examiner that, you've thought about these syndromes, right? So just with one or two questions, just ask, like, have they had just periods of, unresponsiveness or just staring, okay? Whether they've had like sort of muscle twitches, which in the past that he has not really thought much about, like that. So if anyone asks you why, you can say you are like trying to find out whether this could be part of a syndrome. Okay. You can put it in the past sort of, you don't have to take to the past medical history as such in the history of presenting complaint itself. When you are trying to ask about the past history of past episodes, you can bring about those questions. Yeah. Then juvenile absence epilepsy, age of onset is around 9 to 13 years. Okay. Yeah. So just go, no one's going to ask about these percentages, but now just if you know that there are syndromes in adults also, that is more than enough. Okay. Yeah, these are the rare ones, so no one will ask you. Even Kishara said didn't focus much on these. Okay, so we'll look at the etiology of seizures and epilepsy. Okay, so when it's an adolescent and young adult, think about head trauma and drug intoxication and withdrawal. In psych, we will come across these alcohol withdrawal seizures and these other substance-induced seizures and all that. And adolescents, young adults, with these road traffic accidents, falls or whatever, head trauma is also up on the list. Older patient, think about like strokes. Okay, like in that example I gave you, brain tumors. So you can ask about features of tumor like early morning headache, vomiting, and all that. Okay, metabolic disturbances, electrolyte abnormalities, hypoglycemia, and neurodegenerative causes. Okay, so possible etiologies. Yeah. Okay, so diagnostic studies or investigations. If someone asks you, what is the investigation? How do you diagnose an epilepsy or how do you diagnose a seizure? Don't jump into investigations. Say that it is a clinical diagnosis based on a good history or good eyewitness account from a bystander. Okay, so tell that first and then tell there are certain investigations which can help you to come into a diagnosis. Okay. So initially, there are some simple blood works you can do. Number one, investigation or like, especially that sort of status epilepticus sort of setting. First thing would be to do at least a CBS. Okay. Later on, if you're thinking about the course, you can do the electrolytes, especially the sodium and calcium. I told you hyponatremia and hypocalcemia are the common ones. Yeah, we'll go through some MCQs at the end of this. Okay, there weren't a lot of MCQs from the KDO papers. I think 2 or 3 were there. We'll look at some MCQs also. Okay. If you are suspecting of like drug sort of ingestion or intoxication, you can do the toxicology, but don't say this in the beginning itself. Say the simple ones. Okay, say like simple blood work such as blood glucose. Say that first, at least a CBS, then electrolytes, especially sodium and calcium. Toxicology, put it down in the list if you are suspecting this patient to have had some sort of drug ingestion or some sort of substance ingestion. EEG, okay, important investigation, but remember this underlying part. A normal EEG does not exclude a diagnosis of a seizure. Basically, in a patient with epilepsy, the EEG can be normal, okay, and it can be the other way around also. There can be, in a normal person, there can be some abnormal EEGs also. So it can go both ways. Okay, it's only a supportive investigation. It's not really a diagnostic investigation. Okay. It can help in predicting the recurrence of seizures depending on the pattern of, the EEG patterns and stuff. Okay. And it might be helpful in diagnosing epilepsy syndromes. In pediatrics, you might remember that 3 per second spike and wave. It was very specific to one of those seizures. I also can't remember now. So it can help in the diagnosis, but it is not diagnostic, and it can be useful in predicting the recurrence and also diagnosing epilepsy syndromes. Yeah, so it's not a diagnostic investigation. It's useful to assist in the diagnosis. Okay, like I told you before, diagnosis is clinical, like a good history, good eyewitness account. Sometimes, but the patient says it's not reliable because the patient might lose consciousness. He won't know what happened, right? A good eyewitness account. What Kishara sir says in the clinic is basically if what he told the parents was if the person is having another seizure in the future, to obviously do the first first aid measures, left lateral side, and move the person away from danger and stuff like that. and then take the phone and record. Everyone has like a smartphone now, so they can easily record and time the thing. Okay, so then that is like one of the the best things you can do to sort of find out what exactly is happening. Okay, from the patient's side. Ambulatory EEG and video telemetry. Ambulatory EEG is something like it's something like a long-term EEG monitor, something like patient. It's basically the patient can wear the EEG machine. Okay, I don't think it's commonly done here. I'm not too sure. You do it when the diagnosis is doubtful, when you are trying to differentiate between a true epilepsy and a non-epileptic seizure. Okay, so with the ambulatory EEG, what you can do is you can look at the EEG pattern when the patient is having a seizure. You get the patient to wear the EEG throughout, and when the patient is having a seizure, you note that time and stuff, and you look at the EEG pattern to see if it's something like an epileptic form of origin or not. Okay, video telemetry is like pretty much the EEG plus a video. Okay, simultaneous recording of EEG and video of the patient. It can be done as a day procedure or as an inpatient. Okay, so that is also you can do this when the diagnosis is doubtful, but these are not commonly done. Okay, so in your investigation list, tell the basic blood work, glucose, electrolyte, EEG, and when you're saying EEG, say that it's not diagnostic. It can only help in assisting the diagnosis. Okay, and tell that the EEG can be normal in a patient with seizure, and it can be abnormal in a patient without a seizure. So it can go both ways, but say it's helpful, it's not diagnostic. And ambulatory EEG and video telemetry facilities are available. If the diagnosis is still doubtful, you can do it. Okay. Then there are certain imaging studies. Okay, that is when you're suspecting somewhat of like an intracranial lesion of some sort. Okay, then we can do imaging. Okay. CT scan, MRI, and PET scan. Okay, MRI is better than CT. Okay, MRI is generally better for soft tissue than CT. Okay, PET scan can also be done. Especially PET scan is very important if you're planning for epileptic surgery. Find the exact focus. Right. Then treatment decision. Okay, so that is the investigation part. Now we look at the management. Okay, the decision to treat depends on the evaluation of risk and benefit, the risk of subsequent seizure. Okay, so this is what I told before. Say the patient, like a 60-year-old who has had a stroke recently, like 5 or 6 months ago, or maybe some time back, now coming with a seizure which is compatible with the side of the stroke. Okay, then that patient is at a higher risk of subsequent seizure. So then you might have to start with antiepileptic. Okay. Then you have to balance out the risk of treatment also, because antiepileptic drugs have a lot of adverse effects. Okay, so you need to see if treating this patient with antiepileptic drugs is actually beneficial or will it bring about more harm. And particular circumstances of the patient. That means you have to consider the occupation. Right? For example, if it's a bus driver that comes with a seizure, and if the patient is likely to have another seizure in the future, that is not, it's threatening to his life as well as all the passengers. So you might have to consider the occupation also. Right? So you need, when you are discussing in the long case, you'll consider these factors. Okay. If your patient is like a driver or something like that, you tell, because it's very dangerous. You might even start the antiepileptic drugs if you think that the risk is high. Okay. So management, you can divide it into pharmacological and non-pharmacological. Pharmacological would be the drugs, and non-pharmacological are the lifestyle measures, and then there are certain other specific treatments. So we'll look at the pharmacological ones. Okay. So these 2 slides also, I think they are must-know slides, because the antiepileptic drugs you are going to use depends on the type of seizure, because some antiepileptics can worsen certain types of seizures, okay, whereas some epileptics are the first-line drugs. So I'll show you some examples. Okay. Focal seizures, either focal seizures alone or focal seizures with secondary generalization. So focal seizure means the seizure is only on one side, Secondary generalization is it starts from one side and gradually involves both sides. That is secondary generalization. Okay. And for generalized seizure, generalized means both the cerebral hemispheres are involved simultaneously or rapidly. For those two, carbamazepine and lamotrigine are first line. Okay. So don't try and memorize all the drugs that are under these sections. What I did was I just remembered one or two from each section. Okay. Then you won't confuse yourself. Remember the ones that are like common to like sort of the seizure. So carbamazepine and lamotrigine, if you look, they are the first line drugs for both focal seizure and generalized tonic-clonic seizure. Okay. Then clobazam, okay, clobazam, levetiracetam, those are second line for both. Okay. If you can remember, sodium valproate is the first line for GTC, that is also good. Okay. So remember like one or two, don't try to cram yourself with like all these drugs. Carbamazepine, lamotrigine, you use it also, so you can name it as first line for focal and GTC. Clobazam and levetiracetam, second line for both. Then when you come to tonic or atonic, absence seizure and myoclonic seizure, sodium valproate, first line for all three. So remember like that, remember like one or two drugs, which are first line for each of the types. Okay. So you can remember sodium valproate for all three, tonic or atonic, absence and myoclonic. For focal and GTC, carbamazepine, lamotrigine. Okay. But remember, these can be MCQs. Carbamazepine is better to be avoided in tonic or atonic, absence seizure, and myoclonic seizure because it can actually worsen. Okay, so that can be an MCQ. I think that they commonly ask with kids actually, but in medicine also they can ask. Okay. So this slide must know, remember. Okay. Yeah. Yeah. Then we look at the adverse effects. Okay, so adverse effect profile also. Yeah, adverse effects also, you need to know common adverse effects because they can ask. Carbamazepine, you can get rash. Okay. Lamotrigine also, you can get a rash. You can even get what do you call Stevens-Johnson syndrome can occur. Yeah, so the last point about anti-epileptic drugs. So I'll just go through this chart again. I'll tell you what to remember. I'll tell you like what I remember. Okay, don't. So again, we'll go through this table. So for focal seizure and GTC, the focal seizure and GTC, remember first line is carbamazepine and lamotrigine. For GTC, sodium valproate also can come as first line. Second line would be clobazam and levetiracetam. Okay, remember those 2 to 3 drugs for focal and GTC. Tonic, atonic, absence, and myoclonic seizure. Remember first line is sodium valproate, and sodium valproate. Okay. Then in tonic or atonic, absence and myoclonic, carbamazepine, okay, should generally be avoided in all three, okay, because they can actually worsen. Okay. Here, carbamazepine is down the drugs to be avoided, may worsen, they have put it, but yeah, not too sure about that. Maybe remember lamotrigine for GTs. Okay, lamotrigine and sodium valproate for GTs because they've mentioned it here also. I actually just saw it. Okay, so remember like 1 or 2 drugs for each section, okay, because they can ask those. So if you think your patient is having a GTC, say sodium valproate or something. If you think your patient is having absence seizure, you can say sodium valproate. If the examiner asks you, what do you think about carbamazepine for this patient, say you won't use it because it can make it worse. So adverse effects, carbamazepine, rash, diplopia, dizziness, headache. Okay? It's a succinide, the typical nausea, vomiting, drowsiness stuff. Lamotrigine, you can get a rash, you can get Stevens-Johnson syndrome. Okay, levetiracetam, lethargy, irritability, behavioral problems, again, drowsiness, insomnia and stuff. Sodium valproate, it's one of the commonly used antiepileptics. So weight gain, tremors, hair loss, teratogenesis, so contraindicated in pregnancy. So this weight gain is also important. You might have to consider the patient's BMI and stuff like that in your examination. Okay, so these, you don't have to go into detail about this. Drug interactions are also important. Okay, so if there are drugs that induce metabolism of other drugs, okay, you might need to adjust the doses accordingly. So this is the pharmacological part. For example, carbamazepine is an enzyme inducer, right? So if your patient is a young female on an oral contraceptive pill, there can be contraceptive failure. So you will have to advise on barrier methods. So those points can be important, right? With the epilepsy, there's not a lot to go into discussion, so they might dig deep into the drugs. Okay, like the drug interactions, adverse effects, especially if the patient's on other drugs like oral contraceptive pills and stuff, right? And if the patient is already on warfarin and you're trying to put the patient on carbamazepine is an enzyme inducer. So the warfarin will be metabolized faster and action of warfarin would be reduced. So you might have to consider using a different antiepileptic like that. Okay, so I'm not going to go too much into detail. Just basically the gist of it is to find out other conditions that the patient is having and the other drugs and the possible interactions, have some idea. Okay. Yeah, I will tell you how we start and adjust antiepileptic drugs. We'll look at the other non-pharmacological measures as well first. Okay, so pharmacological was the antiepileptic drugs. Okay, and then I tell you the types of antiepileptic drugs for each type of seizure. Then other lifestyle modifications, like you have to encourage them to have adequate sleep, because sleep deprivation can be a triggering factor for epilepsy. Then substances, alcohol, stimulants. If your patient is taking them, you will have to advise them to stop. Okay. So in the exam, if your patient is using substances, you can tell. We will manage with a multidisciplinary team, including a psychiatric team, or a psych referral can be done. Okay. That is not only for the seizure. If we have a patient who came with chest pain, who is chronic smoker, who is a chronic alcohol consuming patient, you can tell you'll work with the MDT and address the patient's substance, the smoking and alcohol. Okay. Then, because they asked me, I also got a patient with chest pain for the long case, and he was smoking. He was at like a 20-pack here smoking or something. And they were like, what else would you refer to? And I was like thinking. And then somehow they were like, wouldn't you do a psychiatric referral? And then it clicked. Okay, so those small points can carry some marks. Avoidance of non-precipitants. Avoidance of non-precipitants, that is also like, I told you, those flashing lights, loud noises, sleep deprivation, okay, stress reduction, your meditation and whatever techniques that they use to reduce stress, just address it. Ketogenic diet. So this is more useful in children, okay, rather than adults. This is a low carbohydrate, low protein, high fat after a period of fasting. Okay, so these ketone bodies that your body forms, especially this beta hydroxybutyrate, is thought to have an anti-seizure effect. Okay, so that is how a ketogenic diet helps in epilepsy or seizures. Okay, so this is mainly useful in children. If your pharmacological measures fail, you might consider in adults also. Okay. Vagus nerve stimulation. This is basically when there's intermittent programmed electrical stimulation of the vagus nerve. Here it says left vagus nerve, so maybe it's done on one side only. No, too sure about that, but stimulating the vagus nerve, and vagus nerve, as you know, it's more of an inhibitory, right? The parasympathetic. Okay. Yeah, here it's a mechanism. I don't know, maybe there's some other mechanisms. Okay. So this is done in Sri Lanka, but it's saved to a last resort, and the drugs are not responsive and stuff. Okay, and then epilepsy surgery. Okay. Right. Yeah, basically another last resort would be epilepsy surgery, especially if they're not responding to pharmacological management and the other measures. Okay. And epilepsy surgery is generally done if it's a focal seizure. So that's where the investigations, the imaging investigation like MRI, PET scans and stuff, to identify the exact focus of origin of the seizure. If you find it, you can sort of resect that part. Okay. Epilepsy surgery is either resection or you can sort of disconnection. There is a disconnect that sort of focus on the rest of the neurons. So they won't go too much into detail as how it's done and all, but just know that these are options, like last resort options. Okay. Pregnancy and epilepsy, mainly know that most of the anti-epileptic drugs, or all the anti-epileptic drugs, have some teratogenic effect. Okay. So in pregnancy, what is safe are these last three: lamotrigine, oxcarbazepine, and levetiracetam are generally the anti-epileptic drugs of choice, okay, in pregnancy. So here what you get is mostly lamotrigine and levetiracetam. So you can use it. Even then there is some risk, okay, but the risks are comparatively less compared to the other, like sodium valproate and all, up to about 10% risk. So these can be MCQs, maybe not in medicine, maybe the general notes papers they can use. Okay. So that is mainly it for the theory part of it. I'll briefly go through how we start and progress with the anti-epileptic drugs, okay? And then go through some points in the history and examination and do some institutes, and we'll finish it out. If there's any questions up to that, just send me a message, or you can unmute and even ask. Anything's fine. So when you start anti-epileptic drugs, and hope I'm not going too fast, it's a bit late also, so I'll try to finish it off soon. If you want me to slow down even, it's fine. Just let me know, okay? So basically, when we take the treatment, something like stepwise, where there are like 4 or 5 steps, okay? So this is step 1. So you can draw this. This was asked a field step also this time, no? In the epileptic question, like how you would start and continue anti-epileptics or something. The principles of anti-epileptic drug treatment. This is what they asked, I think. Most likely is what they asked. These can be asked SCQ, like they ask in a field paper, and even a long case, they can ask, how would you start anti-epileptic drugs? How would you change them? When do you combine them? When do you consider other treatment options? Okay. So step 1 is monotherapy. So you start with one anti-epileptic drugs. I showed you the chart, right? So based on the type of seizure, you start the appropriate anti-epileptic drug. Okay, how you start is you start with the lower dose. You start with the lowest effective dose and then gradually titrate upwards as needed. So you start with the lowest effective dose that is there. If the patient, you follow up. If the patient remains seizure-free, you continue that dose. If the patient is still getting a seizure, you might gradually titrate or gradually increase the dose. So that is step 1. Okay. That is the first monotherapy. Step 1 is first monotherapy. Okay. Step 2 is say you started with one drug, and now we are giving the maximum tolerated dose of drug, the first drug, but the patient is still getting seizures. Then what you do is you stop the first drug and you start the second. You start a second drug. That is also monotherapy. You don't combine it. This is known as second monotherapy. Okay. So step one, you start with one drug, lower dose, gradually increase until effective. It's still not effective. You stop the first drug and you start a second drug. And that is also just the second drug on its own. So since it's a monotherapy, you call it second monotherapy. Okay. Right. Okay, so here also same thing. Second monotherapy, you start with the lower dose, gradually increase. The patient is still having seizures. Then you go to step 3. This is what you call add-on therapy. This is where you start to combine drugs. This is step 3 is when you start to combine anti-epileptic drugs. I told you in that graph also, anti-epileptic drugs have a lot of adverse effects. So you generally try to use one drug. And in that also, you try to use the lowest possible or the lowest effective dose for that patient. So you try to avoid combining drugs as much as possible. So you start combining drugs only when you come to step 3. So before that, you try 2 monotherapies. Okay. Add-on therapy. So step 4 is, despite being on 2 anti-epileptic drugs at the maximum tolerated doses of both, if the patient is still fitting, you can add a third drug. That is known as second add-on. Okay. Step 5. Step 5 is now the patient is on 3 anti-epileptic drugs. The patient is still having seizures. Okay. The patient is still having seizures. That is what we call drug-resistant epilepsy. Okay. Drug-resistant epilepsy. Okay, so I hope this is clear. So this is the principle of anti-epileptic drug use in seizure. So for that PEDS SCQ also, this is pretty much the answer. Okay. And in the long case, if they ask, or in the medicine SCQ next time, if they ask like how would you treat the anti-epileptics, you can give this step-wise thing. Step 1 is first monotherapy, step 2 is second monotherapy, step 3 is add-on therapy, step 4 second add-on, step 5 is drug-resistant epilepsy. Drug-resistant epilepsy, how we treat drug-resistant epilepsies, those other non-pharmacological measures that we mentioned before. That is those ketogenic diet, vagal nerve stimulation, epilepsy surgery. Okay. Here, in addition to this, in step 1, in addition to the first monotherapy, the lifestyle modifications should also be addressed. Okay. So avoiding flashing lights, substance use, stress management, those things also address them in the beginning itself. Okay, so this part is very important. This is also a must-know part. Right. Then next question is, how long do we treat with anti-epileptic drugs? So treatment duration. Treatment duration is until they are seizure free for 2 to 4 years. Not more than 4 years, okay? When they are seizure free for 2 to 4 years, maximum up to 4 years, we can consider stopping the anti-epileptic drugs. It's the treatment duration until they are seizure free for 2 to 4 years. And say you have treated with anti-epileptic drugs and the patient is now seizure free for around 4 years. How do we stop the anti-epileptic drug? Do we suddenly stop it or do we tail it off? So these are questions that they can ask. So how we stop it is we tail it off. Okay, we don't suddenly stop. Because when we are tailing off or when we're stopping the drugs, they can get what we call I can't remember the exact name. I think it's rebound seizure or something. They can basically get seizures when we're tailing off the drugs. Okay, can't remember the exact term. So basically, they can get seizures when you are in the anti-epileptic drugs. Tail off anti-epileptic drugs. Also, there's a way to tail it off. How we tail it off is one anti-epileptic drug will be tailed off over 3 to 6 months. one anti-epileptic to be tailed off over 3 to 6 months. So if the patient is on 2 anti-epileptic drugs, for example, patient on 2 anti-epileptic drugs, okay, then both of them should be tailed off over 6 to 12 months. Hope that's clear. Double. So one anti-epileptic drug should be tailed off over 3 to 6 months. The patient is on 2 anti-epileptics, both of them, you gradually tail them off over 6 to 12 months. Okay. So hope that part's clear. If there's any questions, just send me a message. All right, so these are the questions they can ask you. And yeah, that's, I forgot one more thing. So when it comes to, yeah, so I hope this part's clear, the stepwise progression, drug-resistant epilepsy, how to manage drug-resistant epilepsy, treatment duration, how to tailor. Those are the basic questions that they can ask. The other thing is drug-resistant epilepsy. When you get a patient with drug-resistant epilepsy, you need to think of whether this is truly resistance or whether this is sort of pseudo resistance. Pseudo resistance is basically something like a wrong diagnosis. Okay? It's not a true seizure, it's pseudo seizure that you have missed. That's another difference. In the table I showed you with the difference between epilepsy and pseudo seizure, epilepsy, they are more likely to respond to anti-epileptic drugs, whereas pseudo seizure, they are usually unresponsive. They can be one of the causes of resistance, drug-resistant epilepsy. So pseudo-resistance, wrong diagnosis, like your sort of pseudo seizures, or maybe like underlying causes that have not been treated, maybe like an intracranial tumor. Okay. So you might have to think of alternative diagnosis. Okay, then the other thing is maybe wrong drug. The chart is important. You need to use the correct antiepileptic drug, the correct type of seizure. Wrong drug or inadequate dose or something. Wrong drug or wrong combination drug. Okay. And then you can think of inadequate dose and stuff. Okay. And actually right up there with wrong diagnosis, you might have to think about compliance. Okay. So if we think of drug-resistant epilepsy, if your long case patient is a patient with drug resistance, he's already on like 3 medications, still getting seizures. Before jumping on to these other treatment options, say you would like to, assess the compliance, look into other diagnoses, go through the sort of clinic records and see if the drugs that are given are the correct drugs, the dosing is correct or something like that. Just sort of give 1 or 2 reasons and then say, if still drug resistant, you'll think of the other treatment options. Okay. So this is also must-know part, okay, for the discussion. Right. Yeah, that is really it for the sort of the theory part. We'll quickly look at in the long case history and examination, some points that we need to focus mainly on. Right, I hope that's clear for now. If there's any question, just drop me a message. Yeah, so this is, I think you can see the screen. This is from the long case book. Okay, so this is actually pretty good. Basically, everything you need to ask is there. Some of it might be too much even. Okay, the thing with the epilepsy histories, the patient really might not know what happened. Right, so sometimes you are blank. They don't really tell anything. But you still ask the questions that you want to ask and tell them like, okay, you asked this, but the patient is not aware of what exactly happened. Like the duration of the seizure, if you ask the patient, they might not know properly. Say patient is unaware, he thinks it's around 10 minutes, or like 10 minutes, like 2 minutes or something like that. And then it's better at the beginning or somewhere in the history that you tell okay, this is likely to be an epilepsy, so it's better if you can sort of get a collateral history as well from an eyewitness account, so that you are sort of implying it to the examiner that this is an epilepsy sort of case, and a collateral history from an eyewitness would be a much better account than from the patient itself. Okay, so you can tell it, you do not be scared, because most of the patients sometimes when they have a seizure, they don't know what the hell happened. Okay, so the epilepsy history, you can divide it into the pre-ictal phase, okay, ictal and the post-ictal. Right? So in the pre-ictal phase, basically what you need to ask for is what the patient was doing just prior to the seizure. Basically, from the position of the patient itself is important, because to differentiate seizure and syncope, I tell you syncope is mostly in an upright position. True epilepsy, in any position, you can get the seizure. Okay, what the patient was doing, the seated, standing in the hot sun, was walking, running, whatever. Okay, where was he, what time of the day, and all that. Was there any was there any flashing bright lights? Was he at some sort of concert? Was he at home? Was he at work? Those are all important. Okay, was he in the vehicle? Was it hot? Something like that. Okay. Yeah. Then ictal phase is what sort of happened. So you can ask the patient whether he knows what happened. So if the patient lost consciousness or not. The limbs, were there any jerky movements? Was there stiffening? Stiffening is the tonicity, and the jerky movements are the clonic movements. Okay, and if the limbs are involved, you need to ask what limb, whether it was the arm, the leg, and what side, right side, left side, both the sides. If it's both the sides, then you need to ask whether both the sides were involved from the beginning, like at once itself, or whether initially it was on the right side and then gradually the left side was involved. So these things the patient might know what happened, but you can tell the examiner both sides were involved. However, patient is not aware of whether both sides were involved from the beginning itself, or whether one side was subsequently involved later on. Okay, so that they are telling the examiner that we are trying to differentiate between the generalized seizure and you're trying to differentiate between the focal to bilateral seizure, but the patient is not aware, so you don't have enough detail. Okay? Then whether there was frothing from the mouth, tongue biting, eye rolling, urinary fecal incontinence, and especially whether the patient had any falls or sustained injuries. If so, what were they? How serious were they? Were there bleeding, lacerations? Did they need suturing and all that stuff? Okay, so go into detail about those stuff. That is the ictal phase, and obviously the duration of the ictal phase. That also patient might know exact duration. But if he was told from a bystander, then you can say he was told he was having a fit for this long. Yeah, I think in this sort of they are mainly going through those, right? Yeah, is it a seizure or something else? Is it epilepsy? If epilepsy partial is focal. So these terms are not used, this partial is focal now. Secondary generalized is the focal to bilateral seizure and generalization. What triggered it? Were there any triggering factors? We can ask for the triggering factors, sleep deprivation, substance use, stress, flashing lights and all. Whether it's the first episode or not, recurrence or not. Then the drugs. If it's an already diagnosed patient, then you'll have to ask about the drugs, the compliance, side effects, must ask, okay? So when did the seizure occur, what he or she was doing at the time, with the position of its import, sleeping, walking, sitting, standing. And then the limbs that were involved, loss of consciousness, frothing, falling, trauma, okay, tongue bites, urinary fecal incontinence, okay, duration of the seizure, and also especially important whether there were recurrent fits, and if so, how many? Was there regaining of consciousness in between? Okay, first aid that was given to the patient at the time, patient might not know, but you can tell in the patient's own words. And the post-ictal phase is basically like the drowsiness, sleepiness, headache, body ache, and stuff. Right? Then your differential diagnosis is basically the syncope is the number one DD, so that you already know how to exclude it. So ask a few questions which can be suggestive to a syncope. Okay, then the other main important differential diagnosis is like provoked seizures, whether it's like an unprovoked epilepsy, syncope, or provoked seizure. So provoked seizure are your infections, encephalitis, meningitis. So you already know the basic questions that you asked to exclude cerebral abscesses. Yes, stroke, it could be stroke. Hypoglycemia, whether the patient's a diabetic patient on insulin or oral hypoglycemic, the time he had the last meal before the seizure, important, okay? Electrolyte abnormalities, whether a patient had insignificant vomiting, diarrhea prior to this, okay? Intracranial space occupying lesions, the chronic headache, early morning headache with vomiting, okay? So exclude a few TDs. No need to go into detail like multiple sclerosis, right? So you don't have to ask about that. You can exclude the infections, head trauma, important, I forgot to mention it, stroke, hypoglycemia, electrolyte imbalances, and SOL. That's more than enough. Okay. Yeah. Then if it's a patient with previous episodes, go into detail about those episodes. The treatment, what has been done up to now, the anti-epileptic drugs, where he has been followed up at. Those are also important, especially with the drug adverse effects. If the patient is on anti-epileptic drugs, don't ever forget the adverse effects, like the weight gain, hair loss, flashes. Okay, mention at least one or two of those important ones. There's a lot more detail here. I'll just skip through. Medical history, surgical history, drug, family history, important. Okay. Social history also very important with regards to the occupation. I told you drivers, if they're like construction workers, whether they work at heights, machine operators, okay, shift workers, because sometimes night shift, breaking sleep can worsen the condition. Substance use, important. Danger sites in the house, okay, swimming, bathing. These are very important. It shows that you're thinking about like patient's social aspects, not just the epilepsy person. Examination-wise, full CNS examination, okay? Don't skip any step. Cranial nerve, upper limb, lower limb, cerebellar signs. Okay, everything should be done. I know there's no time, but try and like do as much as you can. And C-based examination was important. I told you pulse, irregular pulse, because arrhythmias can cause syncope. Murmurs, because valvular lesions can cause arrhythmias, which can result in syncope. Okay. Mainly nervous CNS, then CVS also. And for completion, you can do the other examinations, okay? Then the discussion, we went through the investigations and the management, right? Yeah, just one more part. I know it's a lot, but we'll quickly do status epilepticus and then finish from there, okay? So that is also another question that they can ask. So I think this book everyone has, this emergency book. If not, I'll send it on the group. Yeah. So status epilepticus, it's a seizure that lasts longer than 5 minutes or having more than one seizure within 5-minute period without returning to a normal level of consciousness between episodes. If a seizure lasting for more than 5 minutes or repeated seizures where the patient does not regain consciousness between episodes within a 5-minute period. Okay. So how we manage it is, the initial management is similar, okay, like the pediatric one. Okay, the ABCD approach. Okay, acute side bed, call for help and all that. Turn the patient to left lateral side because that will reduce the risk of aspiration. Secure the airway, suck out secretions, prevent tongue falling back with oropharyngeal airway if needed. Okay, and for the breathing part, give high flow oxygen via face mask. At the same time, connect patient to multipolar monitor. Monitor blood pressure, pulse rate, saturation, respiratory rate. Okay, and when you are doing that, check a CBS. Okay, so basically the mnemonic for this is, I know it's ABC, but you can add a other part. So A, B, C is the airway breathing circulation. Then you can, for you to remember, put D, E, F, G. This stands for don't ever get glucose. Okay? So remember it like this, because this CBS, even in the surgery case, not in the surgery case, in surgery questions, for the trauma one, you can put this. Don't ever forget glucose. You can quickly do a CBS. Okay? So all of you do the ABC, now add the DEFG, which is don't ever forget glucose. So you put it into your mind now, so you won't forget it. Okay? So yeah. So check a CBS. If it's hypoglycemic, less than 60 milligram per deciliter, you can do the hypoglycemia management. Okay, I won't go into detail. 50 ml of 50% dextrose IV. Okay. Then try and establish IV access with a large bore cannula, 14 or 16 gauge. If difficult, at least the green one, the 18 gauge. And take blood for investigation. I told you the blood glucose should be done, at least a CBS, so that's already done. Then status, there might be some precipitating cause. So good to do the electrolytes, to look for electrolyte abnormalities, CRP and full blood count in case to like sort of exclude an infection. Okay. Serum creatinine, you might do if you're suspecting of like uremic sort of encephalopathy. Full blood count CRP for meningitis, encephalitis. Okay. Then first line anti-epileptic, there are 3 options. Commonly what is used is IV diazepam up to about 0.2 milligram per kg. Okay. If you can't obtain IV access, give IV midazolam 10 milligram. Okay. If the patient is more than 40 kilos, so most of the adults are more than 40 kilos, so remember 10 milligram. Right? Then if the patient is still fitting, you can give IV phenobarbital 15 milligram per kg, single dose. Okay, or rectal diazepam, but IV phenobarbital is common. Okay. Yeah, so this is between the first, from 5 to 20 minutes you give. After the seizure lasts for more than 5 minutes, you initiate the status epilepticus management. Okay, you don't really wait longer. Use within the first 5 minutes. Once 5 minutes is crossed, you start this IV diazepam or AM midazolam. Okay, within 5 minutes, if the patient is still fitting, you give IV phenobarbital. Okay, and if the patient is still fitting, you can give IV phenytoin, 50 milligram per kg. Okay, so diazepam, phenobarbital, phenytoin. Okay, there are other options, so just remember one of these which are commonly used. So here, first line IV diazepam or IM midazolam. Then you can go for IV phenobarbital. Third line, you can go for IV phenytoin. Okay. And if the patient is still fitting, then only you need to admit to ICU, intubate, and ventilate. Okay. So here onwards, if doses of propofol and thiopentone, they won't really ask. Okay. At the same time, afterwards, or while managing, you need to think and you need to look for and treat any underlying cause like CNS infections, electrolyte imbalances, what you call drug or toxin ingestion, like poisoning and stuff, drug overdose, alcohol withdrawal, stroke, with pregnancy, eclampsia, head injuries, there's history of trauma, like fall or something, might need to do urgent CT, hypoglycemia, and with the blood pressure monitoring, malignant hypertension or a hypertensive emergency. Okay, so I'll send these notes. Yeah, that's mainly it. I think there were like 1 or 2 MCQs in the KDU paper. We just go through that and then start. Okay. Late also, so. Yeah, I was able to find only 2 MCQs, I think, from the KDU ones. We'll go through this, okay, not hard also. Intake 29, question 37, a 70-year-old patient presents with semi-consciousness and seizures. Which of the following investigations do you do first in this patient? Okay, so semi-conscious, fitting. Okay, best would be a random blood sugar. That's the CBS. That's what you do in your initial A, B, C, D, E, F, G part. Okay, don't ever forget glucose. So random blood sugar comes first before the others. So that's the easiest thing to do, rather than random blood sugar CBS. Okay, because random blood sugar will take, you can even do a CBS. Blood sugar is the answer. Okay. In Tech 30, question 33, in a middle-aged woman with partial complex seizures, gets the smell of burning rubber before an attack. Where is the most likely abnormality shown on my ECG? This burning rubber or the smell sort of feature with the seizures is pretty specific for temporal lobe seizures. Okay, this is a commonly asked MCQ. I think most of the PEDS papers have this. Okay, yeah. So that's it. There weren't any SCQ. There was only one SCQ that sort of asked to compare these two. Only like 2 MCQs. Most of the time, epilepsy would come for the long case. And I told you most of the questions that they can ask, especially Kishara, because since he did the lecture, he'll ask what